Hi, everybody. We have all of your slide presentations lined up and ready to go. And we will go name by name. As I'm clicking the slides, feel free, if you are not presenting it directly and you're using the recorded version, feel free to tell me when you'd like me to advance the slide. I'm happy to do so. I know some of you also have some animations that need to be advanced. Just let me know to advance it and I'll take care of that. You'll have 3 minutes to present your presentation. We do have a hard cutoff at 3 minutes. So I will give you that 30-second warning and then cut you off and mute you at 3 minutes. We will then have a question from one of the judges. If you finish your talk in under 3 minutes, then we may have time for a second question from one of the judges as well. I think for the most part, it should be pretty straightforward. Again, if you need me to slow down, speed up, or anything on your slides, let me know and I will take care of that. I'm going to start sharing the screen with our first person who I believe is in the room. Let's see who we have first. Our first presenter will be Alan Qian. Let me just get this ready to go. All right, we're going to share this and begin the day. Right. So this is the Cobb Assembly for 2022. This is the list of our presenters in order that we'll be going. It's generally alphabetical with a couple little changes we needed to make based on when the person can attend the meeting. And we have Alan here. Alan's presentation is pre-recorded, so we should be able to hear everything momentarily.
I know there was a recorded version, but I'm also here. I can do the talk in person. Does that work, Patrick?
Sure. Let me see how to turn off the sound. Let's go back.
Thank you.
Okay. Should be able to talk without it speaking.
Perfect. Well, if there'll be two of me, then that'll be confusing. All right. Well, good evening, everyone. And to everyone on the other side of the world, good morning. My name is Alan Chen. I just finished my second year of medical school at California North State University. Dr. Puglisi is my mentor. He's somewhere in the audience there. During this past pandemic, I started a student interest group called Magic in Medicine with the hopes of teaching performance skills to medical students and hosting virtual magic shows for local child life and pediatric hospitals. During that time, I started working with child life specialists and I became interested in their role working with children with autism spectrum disorder. So by developing a dynamic education module, I hope to sort of ease the anxiety that children with ASD experience when going through the delivery of healthcare. We go next slide. Thank you. So I'll tell you a quick story. There was one magic show a few years ago. A young boy came up to the magician and said, is it possible that I can go on stage today? My mom usually doesn't let me. Brave, right? I wouldn't do that. It turns out that magician was Dr. Puglisi, my mentor, and that boy had been previously diagnosed with autism spectrum disorder. That night, the boy did go on stage, not once, but twice, and returned the next year. So I guess it was a good show. But what does all of this have to do with the Scream from 1895? Well, where you and I might scream and run away from a situation where a magician calls us to go on stage, this young boy didn't. He experiences the world a little differently. In this case, magic for him was motivational, it was calming, and it met a need to be seen and heard. Now, these three benefits that you see on the slides have been proven inside of a classroom and also in a clinical trial, but for neurotypical pediatrics. And then for the final point, the need. There has been a need financially. Only 5% of current private and public funding for autism research is being put into services and 2.5% for transitioning from middle school, high school, those sorts of life experiences. At the same time, child life specialists in a survey have shown an increase, a want to have more exposure to children with ASD, working with children with ASD. Next slide. So how do we plan to tackle this issue? We hope to use personalized magic for child life specialists and their patients and families. It'll start with the 1-hour magic workshop where we teach basic magic tricks using sleight of hand or gimmicks and toys. So very easy to learn. We follow up in 2 months just to evaluate whether this pilot study can work. What are the difficult aspects of interactions? Are there any specific problems that can be addressed? Is this approach practical? During which Dr. Pulisi and I will spend time doing research and development to address these new specific requests and host a new workshop. Next slide. So some of our goals for this study, from individual experiences, we'd like to document child life specialists' unique experiences working with children with ASD. We'd like to
30
hopefully
seconds.
expand these positive experiences to patients, caregivers, and advocates. So expanding these workshops. And then maybe expand these practices to pediatricians and child life specialists working with other populations. One that came up during this project was type 1 diabetics. And then maybe eventually take this to a national level. The main goal here is that maybe magic can bridge these two realities that we have and help.
Alan, I needed to cut you there. Sorry about that, my friend. But thank you for presenting. We will have these available as well for anyone to listen to or look at afterwards. But I see we do have some questions. Mike Fox, if you want to handle the questions.
All right, so the honor of the first question of the evening goes to Barbara Schildkrod. Barbara, please ask your question. I don't know if you're still muted, Barbara. All right, so we'll go to our backup.
I'm sorry. So Alan, could you comment on the experience of individuals who have ASD with magic, given that theory of mind is sometimes important in understanding a magic trick?
Yeah, so I have a colleague who works primarily with children with autism spectrum disorder. And of course, there needs to be some level of functioning. Current trials have been done mostly with high functioning adolescents with autism spectrum disorder. So there's that. But there has been a lot of work from neuroscientists on the East Coast and also just practicing magicians saying, well, people with autism spectrum disorder can't experience magic or they won't get it. And I think that's true. I think neurotypical magic that is currently presented would probably work terribly for the average individual with autism spectrum disorder. So I think one of the goals of this project is also to understand, well, what works best, because I do think experientially that they can experience magic and wonder and all of these things.
Thanks very much.
Thank you, Barbara. Thank you, Alan. The next person I have presenting is Natalie Ehrlich-Malona. Natalie, are you in the room?
Yes, I'm here. Can you hear me?
We can hear you. Would you like to present it with sound? Do you have the sound pre-recorded?
No, I don't.
Okay, perfect. So I'm going to just, perfect. Let's get this shared and we'll go from there.
Just a quick reminder to the judges, please enter your score on the online spreadsheet.
All right, and let me just click this. There we go, Natalie.
All right, thank you. I'm Natalie Ehrlich-Malona. I'm going to talk about paroxysmal hypothermia with prominent Parkinsonian features after suprachiasmatic tumor resection. Next slide. This talk was conceived when I was consulted on a woman in her late 70s with a history of pituitary adenoma resection 10 years prior, who was presenting to the ED with a chief complaint of slowness and balance dysfunction. Her daughter accompanied her and described that over the past couple of weeks, she had noticed her appearing stiff, keeping her arms flexed at her sides, and having to hold on to furniture to balance when walking in the house. On my exam, she appeared Parkinsonian, and her cognitive testing was below her baseline. Vital signs were remarkable for hypothermia to 92 degrees Fahrenheit and bradycardia to 48. On reviewing her chart, I discovered that she had presented similarly twice before. Eventually, we diagnosed her with paroxysmal hypothermia, a rare but well-described syndrome. A few months later, I encountered a similar presentation in a pediatric patient. Here's a table of clinical characteristics of these two patients. Both had a history of suprachiasmatic tumor resection and subsequent hypothalamic pituitary insufficiency and seizure disorder. They each presented multiple times with hypothermia and bradycardia, thrombocytopenia, and transaminitis, with EEG demonstrating diffuse slowing with FERDA. Both patients presented, next slide, with bradykinesia, balance dysfunction, tremor, and hypomimia, in addition to decreased deep tendon reflexes, encephalopathy, and dysphagia. There was no history of dopaminergic medication use, and both patients had complete resolution of these symptoms between episodes. The pediatric patient was started on cyproheptadine, has had no further episodes for the past 15 months. The elderly patient was seen by movement disorders and neurodegenerative disease specialists in follow-up, and questions of Lewy body dementia and Parkinson's disease, which had been raised, were dismissed. She was also started on cyproheptadine, but unfortunately continued to have further episodes. Prior cases in the literature have mentioned bradykinesia, ataxia, and dysarthria, but Parkinsonism has not been described as a specific feature of paroxysmal hypothermia. However, in exploring the relationship between hypothermia and Parkinsonism, I came across this interesting passage in a paper by Temple Fay and Gerald Smith from 1941 entitled Observations on Reflex Responses During Prolonged Periods of Human Refrigeration. The patients displayed waxy stiffness, a flexed position of the extremities. I was still on that slide. And in coordination that became more pronounced as the temperature continued to fall. All volitional movements became progressively slower. The slow hypertonic movements of the Parkinsonian state are simulated, though the incoordination here was more pronounced. Next slide. Here's a diagnostic algorithm and scoring tool I designed based on both my experience with these two patients and a review of the literature on pH, which could potentially help guide management of these patients. The patients tend to present either in an unresponsive state or with insidious onset of bradykinesia, balance dysfunction, and encephalopathy. Ultimately, the flowchart leads to a 4-point scoring system with 1 point each for prior episodes, MRI showing hypopolarization, thrombocytopenia, and EEG with FIRDA. Thank you very much. That's it.
All right, judges, please raise your hand or enter a question in the chat. Dr. Press.
Wonderful presentation, very interesting. Do you have any thoughts on what the potential mechanism might be for Parkinsonism in this scenario?
Yeah, I mean, I was trying to come up with it, and it was everything that I found. You would expect the opposite, because most of the studies that have been done with dopaminergic drugs or observations that have been made, increased dopamine was associated with hypothermia rather than the opposite. So it's hard to tell. It's something, I don't know if it's a negative feedback mechanism, but I don't know. Very curious.
Yeah, I had no thoughts either. I was at a loss as to why that would be.
Great job, Natalie. I appreciate you presenting for us today. It seems like everyone else does too. Again, these slides will be available if anyone would like to rewatch this. We are recording it and we'll be posting it on our BSNNP YouTube page. The next person I have, I do not want to butcher this name, Maniz. Are you on the call?
Yes, I am. It's Manija.
Great. Nice to meet you. I'm going to get you started if you're ready to go, and we will start the timer.
Thank you. I want to talk about fentanyl-induced amnestic syndrome, also through a case that I saw. And I think you have to advance really fast on my slides because each line has a click on it. It's going to be time consuming. So it was a 32-year-old right-handed male with bipolar mood disorder. He was a college graduate and he was a high-functioning person. He had history of binge drinking and also cocaine use. He used some cocaine with his friend one day and then took some fentanyl tablets that his friend provided. And the following day, he was found by his family with confusion. He was brought to ED. Initial investigation, initial clinical exam was unremarkable, except for the fact that he was repeating the same question over and over again. Lab testing only showed positive toxic screen for fentanyl. He was started on acyclovir and he was sent to us for further investigation. We did the MRI on day 2 that showed bilateral hippocampal diffusion restriction. And it resolved when we repeated the study a week later. We did a neuropsych testing on him, and it showed significant difficulty with encoding and less severe difficulty with semantic memory. I looked at the literature, and there's a lot of studies showing that use of fentanyl, street fentanyl, is increasing in the United States, and it is also associated with a lot of death because of this. And there is also several reports of patients with bilateral hippocampal injury and leading to acute amnestic syndrome using street fentanyl. There is not a lot of long-term studies on it, but there was a case report of a patient who presented 4 months after the incident, and the study showed that he had hippocampal atrophy. It seems like in our case, we started him on a speech therapy right after discharge, and he was able to cope with his memory problem and was able to go back to work as a full-time employee 3 months after the incident, but he's still making extensive notes and setting alarms to be able to function. In conclusion, I think it is a very important, the cause of this is most likely to be anoxic brain injury because of respiratory depression, but it also might be related to a toxin that we don't know, which is present in the street fentanyl.
Looks like the timer just timed out. So we have a question from our judges. Dr. Samuels, please.
Islami, that was a very, very interesting case. I wonder what you think this can teach us about transient global amnesia.
You can unmute yourself, Manisha.
Sorry. I think it can be a similar problem with anoxic injury or ischemia, but usually I don't know if it's bilateral in case of transient global amnesia, and it is definitely I think it's transient global amnesia by definition goes away in a few hours. So this is more profound, but it could be a similar pathophysiology, but more transient in case of transient global amnesia.
Thank you very much. It was a lovely case.
You're welcome. Thank you for the opportunity.
Okay, thank you so much for your presentation. We next have Hayden Ferguson available. Are you here, Hayden?
Yes, I'm here.
Great. And apparently your slides were a little funky, so bear with me 1 second. Something about how they were inserted. So I have you in a different screen. And I'll share this. Stop sharing. All right. You can begin.
Great, thank you. Good evening. My name is Hayden Ferguson. I just completed my 3rd year in the clinical psychology program at William James College. I'll be presenting tonight on my research on neuroethics, public opinion about neurotechnology, and the preliminary psychometric properties of a measure of neuroethical orientation. Next slide, please. Advances in neurotechnology and new applications of existing neurotechnology, such as deep brain stimulation, are being implemented more and more. Many of the people in this room have contributed to these advances. With ongoing evolution of neurological interventions, the budding field of neuroethics has emerged. However, the current neuroethical literature is notably void of the public's opinion. To address this void, we distributed a survey adapted from a structured interview used in a qualitative study of neurosurgeons' perceptions of psychosurgery and neuroenhancement. If you could click, please. We collected demographic data, participant familiarity with DBS, and likelihood to pursue DBS for a medical or neurological disorder if it was recommended. Participants were then shown 10 short vignettes and asked for their neuroethical approval or disapproval of hypothetical uses of DBS, brain implants, and other neurosurgeries. If you could click, please. This is an example of one of the vignettes. If you could click again. And one more time. The sample of 93 participants was predominantly female identifying, white or European, and college educated, with 74% of them having a bachelor's degree or higher. 63% of the sample was at least familiar with DBS, with 31% of the sample knowing someone with a DBS device, primarily for Parkinson's disease. Next slide, please. A construct analysis of the neuroethical questions identified 7 scales that formed the proposed measure. So these scales include human enhancement, treatment of psychological disorders, threats to humanity or personhood, alteration of core identity elements, memory erasure, disease prevention, and punishment. Cronbach's alpha demonstrated overall strong reliability and internal consistency. If you could click, please. Multiple regression analyses demonstrated that male identified gender and higher scores on the treatment of psychological disorders scale significantly predicted a person's likelihood to pursue DBS. Next slide. The sample's average performance on the 7 scales is demonstrated here within the context of each scale's range. So as you can see, the sample overall highly improved the treatment of psychological disorders, but was very aversive to anything that threatened their humanity or personhood. The clinical applications of this could include pre-surgical screening or treatment outcomes if an individual may have a neuroethical aversion to one of these life.
Sorry about that. He didn't have to cut you off, but you got, I think, just read everything in there under the wire. Great presentation, Dr. Fox.
Another question from our judges, please raise your hand. Dr. Perez.
A nice presentation. I'm curious if there are any comparative studies or efforts to move in the direction of understanding how patients might think about neuromodulation and brain-based interventions versus other interventions, for example, cardiac, that might have the same level of invasiveness, but not personhood. Any sort of comments around this?
Yeah, so some of the similar research and sort of my inspiration for looking at this was within the context of research on cochlear implants or on prosthetic limbs, of basically how does a person integrate the biotechnology into their sense of self. So I think that the brain implants, or a neurosurgery does have that invasive nature, but there's this additional sense of self or identity element that may be not as present in a cardiac intervention. Thank you.
Thanks so much, Hayden. Let me just get out of yours and go back to the original set. All right. And we had Natalie over here. David Fisher, are you available?
Yep.
Great. Let me just get this started for you. Why is this not working? Slideshow.
I apologize if you can hear my kids screaming in the background.
It's all right. I'm having an issue getting your slideshow going. Hold on one second.
We're family friendly.
I'm just going to restart that slide deck. Bear with me.
And I want to thank everybody for tolerating our technical difficulties. There was a very, very low probability that the first ever virtual Cobb assembly would go flawless, but I'd say so far it's actually run very, very smoothly. But thank you for bearing with us.
All right, we've got it working again. Let me just share the screen. All right. All right, David, and we're off.
All right, thanks. So I'm David. I'm one of the neurocritical care fellows at Mass General Brigham, and I'm going to be talking about a study I led on disorders of consciousness associated with COVID-19. During the initial wave of the pandemic, I was actually a resident on the neurology consult service, and we were being inundated with consults for patients in the MICU who had survived this severe critical illness of COVID-19, but weren't waking up days, weeks, and sometimes even months after sedation had been discontinued. And we were consulted to comment on their prognosis, but we didn't know what was causing these disorders, let alone what their prospects for recovery looked like. And so in some cases, patients had their life-sustaining treatment withdrawn on the basis of that uncertainty, and they died. So in response to that, we launched a prospective study called the Prognostication of Recovery in Early Disorders of Consciousness after COVID-19 to try to help address that issue. I'm going to be talking about the main results from that. You can advance twice. All right, so these were not straightforward patients to enroll. In order to identify these patients, we had to screen over 1,000 patients admitted with COVID-19 admitted to the hospital in order to identify a select group of patients who had a disorder of consciousness that wasn't related to their sedation or brain injury. And we were able to ultimately identify 12, which doesn't sound like a lot, but it's actually one of the largest cohorts of this condition to date and the only prospective cohort of this condition that's been measured. And the most important finding here is if you look at these bars on the right, where the blue bars represent how long they were intubated and sedated for, and the red bars represent how long they were unconscious for, all of these patients invariably recovered consciousness days or weeks after their sedation was discontinued. Some of them did have some underlying structural brain injury. Some had microhemorrhages or leukoencephalopathy, which had been associated with COVID-19, but most were relatively mild and didn't seem to explain the overall disorder of consciousness. You can advance twice. We also did some advanced neuroimaging. We did functional MRI to measure functional brain networks and found that their functional brain networks were significantly diminished as compared to healthy controls. And we also did diffusion tensor imaging to measure their underlying structural brain networks and found that their structural brain networks were also severely diminished as compared to healthy controls. And in fact, were comparable to patients with severe traumatic brain injury. You can advance. We then continued to follow these patients up to a year after their hospital discharge and found that the vast majority regained substantial neurologic function in the following months. By a year, the vast majority of these patients were totally independent and symptom-free, although there were a couple of patients who had ongoing disability due to a severe concomitant neuropathy. So our hope is that these data help inform prognosis and help to inform the underlying pathophysiology of this condition. We have had a few messages from families and clinical teams across the country expressing that they were going to withdraw life-sustaining treatment until they saw these data. So our hope is that these data will continue to make a difference for patients with COVID-19.
Great, David, you completed that with 39 seconds left. So if we have more than one question, we're happy to give them both to you, Dr. Fox.
First up, Dr. Samuels.
David, that was very interesting. I wonder where you think the lesion could be at the top of the the ascending reticular activating system in the thalamus. It seems to be fairly diffuse from your pictures, bilateral, front and back. What do you think could be happening for so many weeks or months and be reversible?
Yeah, I think that I don't think these are focal lesions. I think, as you said, I think they are diffuse. We did a lot of sub-analyses to try to understand what kind of toxic metabolic insults might be contributing to this, looking at the degree of hypoxemia, looking at the total amount of sedation they received over their hospitalization, and none had a totally significant correlation. The one that was closest was the presence of severe renal dysfunction and uremia seemed to be a contributor. So I think ultimately the lesson for me here is that probably these disorders of consciousness in COVID-19 most closely resemble a toxic metabolic encephalopathy due to diffuse cortical dysfunction. And I don't think it's necessarily due to a focal lesion in the ascending reticular activating system.
Dr. Perez.
David, nice presentation. Could you comment briefly on the utility of resting state fMRI versus FDG PET in these kinds of cases?
Yeah, essentially, we were interested in looking at their underlying brain function, but this was done during the initial wave of the pandemic where we were very much restricted in the kinds of studies that we could do. The only reason we were able to obtain any of these advanced imaging methods for patients who were critically ill with COVID-19 was because we could addend it onto a clinically indicated MRI. And so we took advantage of the fact that we can use resting state fMRI. And there are a couple of advantages of resting state fMRI. It's been shown to, the degree of functional network connectivity on resting state fMRI has been shown to correlate with levels of consciousness and has also been shown to correlate with prognosis. And so that was the rationale for looking at functional network connectivity in this case. Certainly FDG PET would have been fascinating as well. We also know that there are similar associations with consciousness associated with cerebral metabolism, but unfortunately, logistically, we couldn't get that done for these critically ill patients.
All right, thank you. Let's move on to the next speaker.
Great. Next, we have Rishabh Gupta. Are you with us, Rishabh?
I am, yes. Is it possible to play the video? I worked hard to record that in 3 minutes.
Sure, let's see if we can get this going for you. Is there supposed to be sound with this?
No, yeah, there is a video file, separate video file that I uploaded.
Okay. That was not included here. Let me just see. Bear with us, everybody, again. Technical difficulties. I don't see a file here, but Michael might have put it somewhere else. Bear with me.
Rashad, if we're not able to track down your video file, you're comfortable being put on the spot?
Yes, I am.
Yeah, it looks like it may have been uploaded without sound, but I'm going to try it one more time. We'll see what happens.
The sound was embedded in it. It was an MP4 file.
Yeah, they have been playing automatically when they've been embedded, so I'm not sure why yours isn't working, but we're going to try it one more time.
Yeah, otherwise I'll just present.
Okay, let me just share this. Hopefully we can do this in person next year, everybody. Although I do like doing it from my dining room.
For those that have never attended the Cobb Assembly before, there's a lot more wine in person.
All right, let's try this again. All right, will it make sound? No, I'm sorry, Rashad.
Okay, no worries. That's totally fine. So I'll start. Hi, good evening, everyone. I'm a final year fellow in behavioral neurology and neuropsychiatry at Brigham. Today, I'm going to talk about a very atypical case of temporal lobe epilepsy, which lies at the junction of psychiatry, neurology, and sleep medicine. Before I go into the case, I wanted to also give a brief overview of temporal lobe epilepsy, which, as you may know, peaks in old adults, and the late onset temporal lobe epilepsy happens more so in those patients who are less likely to have hippocampal sclerosis, and the etiologies mainly include acquired brain injury, including traumatic brain injury, stroke, neurodegenerative disease, and occult cerebrovascular disease. And in a large proportion of patients, the etiology remains unknown despite adequate workup. And another reason to present this case was the fascinating symptoms and the fact that this patient's symptoms stumped 3 epileptologists and neuropsychiatrists at 2 big academic medical centers. So now coming to the case, this was a 67-year-old right-handed man with anxiety who was doing well in his life till age 61 when he developed constellation of neuropsychiatric symptoms, mainly brief intrusions of dreams into his waking life. Next slide, please. Please keep clicking. These dream intrusions were associated with paroxysmal fear, leading to post-ictal altered cognition, which could last up to 2 hours. And the patient also had vivid dreams, poor quality sleep, and a lot of visuospatial difficulties and forgetfulness, but with impaired instrumental activities of daily living. So and he, keep clicking, please. And he did not have any history of substance use for several decades, had family history of Alzheimer's disease in his uncle. On examination, he had some increase in psychomotor activity suggestive of anxiety. A comprehensive workup did not yield anything substantive except for mild OSA. So with with this information in mind, we entertained 4 possibilities: atypical anxiety disorder, possible epilepsy, possible OSA, and possible neurodegenerative disease. So this patient was treated with psychotherapy, CPAP, buspirone for anxiety, and then he dropped out of treatment. And then he came to me after 4 years of symptom onset. And then I gave him lamotrigine for possible epilepsy because he was not willing to undergo EEG for a diagnostic workup. and then venlafaxine for anxiety. And he discontinued both of them prematurely because of side effects. Finally, after working with him for 6 months, I convinced him to get EEG. And this time EEG did show epileptiform discharges. As you can see here, please keep clicking. One more. And the MRI brain repeated came back.
All right. So, sorry, Rashad. Thank you so much for being put on the spot. This is a new skill set where you're put on the spot and have someone else advance your complicated slides. But thank you so much for tolerating the lack of the video.
I will continue to click through your slides just so people can see your work because it should be seen. And again, this will all be visible online. And if you're all comfortable sharing the slides, and we can also do that as well. Thank you, Rashad.
One question from the judging panel.
Dr. Press?
Yeah, Rashad, do you think there could be a relationship between his seizures and a neurodegenerative disorder, or do you think it's just an isolated seizure disorder?
Yeah, we actually ruled out neurodegenerative disease in him because there was no progression of cognitive deficits. Neuropsych testing also did not yield anything indicating neurodegenerative disease. MRI was negative for that also. So we think that might be contributed by obstructive sleep apnea, possible epilepsy and anxiety, like occurring together, leading to cognitive deficit.
Got it. Thank you.
Thank you so much, Rashad. Let's move on to Dan Harrison.
Dan, are you
Perfect.
present?
I'm here. There's a small possibility that there will be a version of me from 4 weeks ago talking in the bottom right-hand corner of these slides. And if that person talks, then I will shut my mouth. But
all right, I believe it talks. Let's find out.
All right, perfect. That sounds good. So good.
You are talking.
Yeah, no audio coming through though, Patrick.
No, oh, interesting.
We could maybe just pause the video if that works, and then I can just give the presentation live. But I'm Dan Harrison. I'm one of the chief residents at MGB, and I'm going to tell you a little bit about the review of neurologic education and PA programs that I've been working on with Chris Doty at Brigham and Women's Hospital. So I think all the neurologists that are here know that essentially right now there's a major shortage of neurologists in the United States. There have been a lot of different solutions that have been proposed to address this problem, one of which has been increasing the advanced practice provider, or APP, workforce in neurology. However, focus group level data suggests that APPs report having limited formal neurologic training in their undergraduate medical education programs. That being said, there's not been a comprehensive review of neurologic education and PA programs. So what we did is a survey of accredited PA programs to get a sense of what kind of didactic and clinical neurologic education is offered. And then we also reviewed program websites for content regarding neurologic education. I'll just present some of our key results. We did get some information from the program director survey about neuroscience didactic topics that are covered. So almost every program out of the 60 respondents we had covered neuroanatomy, neuropharmacology, neurophysiology, neurologic disease, and neurologic exam. But only about 2/3 of programs actually offered any instruction in neuroradiology or neuropathology. When there was a dedicated neuroscience course, the course director was most often not someone trained in the neurosciences. So that is not a neurology PA, neurosurgery PA, neurologist, or neuroscientist. And then in addition to those findings, we also found that there was only a dedicated neuroscience course in about 43% of programs, at least from survey data. When we did a website review, it looked actually like a smaller number, about 21% of programs. Those numbers only moderately agreed. And then there was a required neurology rotation in only one program, clinical rotation, only one program in the country, but elective neurology rotations in about 85% of programs. Ultimately, all of this taken together, we think that topics in neuroscience that are covered routinely are most often not taught by an individual specialized in the neurosciences. Neurology clinical rotations are nearly never required, and many programs don't actually offer neurology electives. Neuroradiology and neuropathology, because they're only taught in about 2/3 of programs, really should be targets of postgraduate neurology PA education. And then ultimately our data from survey and then website review didn't agree. So really probably can't take program website data at its face value. We do want to do this study in nurse practitioner programs and think that it's important to really understand PA and nurse practitioner education at the undergraduate level to make sure that we design effective educational interventions for PAs and NPs practicing neurology after they've graduated.
I apologize if that moved forward probably a little bit quicker than you're speaking. It looks like your timing is set up to go with your original video, so it just kind of auto moved on me.
That's okay. That's fine.
We do have a few seconds. You did finish a little bit early, so it looks like we do have a question from Dr. Silversweig, and then if we have anyone else, we can take a second question.
Yeah, thank you. That was really important project with a lot of implications. What roles or limitations of roles do you see for PAs in neurology if this becomes more promulgated and widespread?
Yeah, that's a great question. I will say in my limited time as a neurology resident and a medical student working in neurology, there have been times where I've been in the hospital and there have been 2 other neurologists in the hospital and 1 PA in the hospital. And there are 4 patients who have acute decompensations in their neurologic exam at one time. And the 3 neurologists go to see 3 of the patients and the physician assistant goes to see the 4th patient. And as physician assistants and nurse practitioners become more and more experienced and have more clinical training in neurology, then often those are the folks that end up teaching the kind of like early career neurology residents the kind of basic facets of being a neurologist. Doing lumbar puncture, I learned from a physician assistant or 2 physician assistants. So I think there can be pretty significant roles both in educating neurology residents, but also in taking care of our patients and helping us take care of our patients, both in the hospital and in the clinic.
Thank you, Dan, for that comprehensive answer. For the sake of time, I think we should move on to the next speaker, though.
Ivana Joseph. Ivana, are you present?
Ivana is currently on night float, so there's a chance she may not have joined us.
Okay. This is a narrate. Can you hear the narration?
Patrick, you might need to share and turn on the audio when you actually share your screen. So maybe unshare your screen, try and share it again. And then there's oftentimes an option to either optimize for video or share with audio.
Let's see. All right, so let me go back and start her over. She's very faint as well, so.
I'm Ivana Joseph, a PGY2 over at Tufts Medical Center.
We can hear it now, it's just very soft.
Yeah, I have it turned up all the way on mine, so you may want to turn up your own volume.
And I'm going to be talking about a study we conducted in our sister hospital, Beth Israel Leahy, named Patient Factors Associated with Organ Procurement Following Death by Neurological Criteria.
Anyone who's unmuted, please mute.
So why this study? Based on the Organ Procurement Organization report for Massachusetts collected between 2016 to 2021, it was identified the average number of organs procured were more in death by brain death compared to death by circulatory death, with an average of 3:1, as we can see in this graph taken directly from the Organ Procurement report. A part of being a neurointensivist includes performing brain death exams regularly and taking care of patients who are potential organ donors. Hence, we were curious as to see what patient characteristics affected the time to organ procurement in our institution. We conducted a retrospective study where the cohort of patients between June 2015 to October 2019 were selected. ICD codes 9 and 10 were used to identify the patients. We used student t-test and multivariate regression modeling in SAS to analyze the data. The variables included in the study were time of admission to organ procurement, age of the patient, the APOE2 score, which is a widely used ICU mortality predictive score, number of vasopressors used, acute kidney injury, and acute liver failure. Moving on to results. Our initial search identified 66 patients, but only 37 were included in the final analysis, as the other patients did not undergo brain death testing. 6 of the 37 patients did not undergo organ procurement. What we noted with the rest of the patients was that the time from admission to organ procurement did not affect successful organ procurement or number of viable organs, with a p-value of 0.75. Multivariate analysis demonstrated time from admission to organ procurement was independent of age, number of vasopressor medications, the APOE score, and acute kidney injury. but was related to acute liver failure with a p-value of less than 0.01. In conclusion, our single center death by neurological criteria or brain death organ procurement and implantation were independent of time from admission to organ procurement. Interestingly, acute liver failure was associated with increased time to organ procurement. Additional larger cohort studies should be reviewed in order to confirm our findings. Thank you very much.
Okay, so that was that one. We can
move on to the next speaker.
On to Mariana Kapsataki. Mariana. All right, this looks like it's also recorded, so I'm just going to boost the volume again and share it back again. Oops. All right, let's see. To set up to share to a different screen. Mariana. This will be called Race and Gender Disparities Among Neurologists Working in the UK. Can everyone see that screen?
Yep, go and play.
Hello, I'm Dr. Mariana Kapsataki. I'm an honorary postdoctoral research fellow at UCL and also a medical doctor working in Greece. Today, I would like to present to you a study that I conducted recently. So this study aimed to examine the educational background, research and teaching activities of neurologists in the UK, and in particular, whether these are related to their skin color and gender. To my knowledge, this is the first study to examine these factors among UK neurologists. So I did an online search of consultant neurologists working in the UK between December last year and March this year. I collected data from biographies and Google Scholar regarding the educational background, the research activity and teaching activity of neurologists. I used their name and photo to extract information regarding their gender. And I used their photo to extract information about their skin color. I found that 1,021 consultant neurologists were working in the UK during the period I did the online search. There was predominance of men, both at consultant level and at full professor level. There was predominance of white color skin, both at consultant level and at full professor level. There was predominance of PhD education level. And regarding the obtainment of PhD or equivalent level of education, there was no gender disparity, but there was skin color disparity. So only 36% of consultants with black skin color had been awarded this degree. This study revealed that there are gender and skin color disparities among consultant neurologists in the UK. Further work includes examining neurologists' educational background and research activity in more detail, as well as examining factors that may have impacted their career success. Thank you very much. If you have any questions, please don't hesitate to contact me.
And Marianne, are you on with us today? All right, let's move on to the next speaker.
Yep. All right, next up we have, sorry, I'm in the wrong screen here. Peter Loro.
Yeah, that's me. Can you hear me?
Yep.
Great. So thank you for having me. My name is Pete Loro. I'm an 8th year MD PhD student here at Brown, and today I'm talking about my research with patients with obsessive compulsive disorder. Next slide, please. So OCD is a common neuropsychiatric disorder characterized by intrusive obsessive thoughts such as incompleteness or imminent harm that compels behaviors to engage in repetitive compulsive behaviors. And from a reinforcement learning framework, we can understand this to be an inability to update patients' cognitive models in light of experience. Instead, they habitually engage in obsessive compulsive overlearned habits. And here at Brown, we have a unique patient population of patients with OCD who undergo surgical ablation of the anterior limb, the internal capsule, shown in the bottom left figure there, that helps relieve symptoms. We show the change in the bottom right figure showing the Y-box score before and after surgery. Next slide, please. And because we don't know the mechanism of the surgery per se, and we were interested in this question of impaired learning in OCD, we took these surgical patients and had them engage in this navigation task we called grid world. So the top row shows an example. So patients are dropped in one square in the grid and are instructed to navigate to the reward location indicated by the green square. And patients initially are freely able to navigate the maze in the unobstructed condition, but based on their behavior and movements, the second condition, the obstructed, places roadblocks which probe the patient's understanding of the entire layout of the grid. And patients perform this task before and after surgery, and we quantify patient performance by simple measures such as the number of moves over the optimal path and whether or not a patient found the optimal path. And the bottom figures here are showing that in general, when compared to age-matched controls, patients with OCD have impaired performance, so more moves to get to the reward, and they don't always find the optimal path. But to get directly at this question of model-free versus model-based learning, we also quantified learning parameters using reinforcement learning agents trained on patient behavior. Next slide, please. And so one of these model-free parameters, alpha, the learning rate, shown in the top left corner here, is again, there's a main effect of a difference where patients with OCD have a lower learning rate than controls. However, there was a trend of an interaction where after surgery, the patient's learning rate was more like that of controls. Similarly, the top right figure showing the model-based index, just quantifying how much patients use information from the whole grid, again, was lowered in patients with OCD with the trend towards an interaction where patients had control-like model-based index after surgery.
30 seconds.
And with these behavioral parameters and behavioral metrics and learning parameters, we can calculate the change in patients with surgery. And we correlated these changes with the tractography passing through the lesion. And in the bottom left corner, we showed that an increase in finding the optimal path was associated with hippocampal fibers intersecting the lesion. On the contrary, orbital frontal fibers passing the lesion was associated with decreases in model-based strategies. So I hope I've shown you that patients with OCD have impaired learning strategies with trends that it's normalized by surgery, and these changes are mediated by lesions in orbital frontal hippocampal networks. Thank you.
Perfect timing. Do we have any questions?
Dr. Perez?
Peter, nice talk. Might the effect that you're seeing here be related to the severity of OCD pre and post, meaning that there's intrusions, obsessions, and compulsions that impede their ability to participate in this task, and it's not so much that you're finding differences in reward processing per se, or the construct being tested by this probe?
So I didn't show the data here, but we did correlate the changes in Y-box with the changes in learning parameters. And in general, there wasn't any sort of significant correlations between them. And just as another note, the spatial layout that patients encounter is different in each time point. So it's just simply testing the learning strategy, not remembering the objects.
Thank you, Peter, for that great talk. Let's move on to the next question or next presenter.
So next person we have, oops, we're back to Rashab. So next person we have is Giancarlo Minucci Jimenez. Are you with us, Giancarlo?
Yes, I'm here.
Okay, great. Let me just share this. All right.
Okay, thank you, Patrick. Good morning, good afternoon, everyone. Thank you, everyone, for being here. My name is Giancarlo Minucci Jimenez. I'm a neurosurgical research fellow at Bayer Neurological Institute. Today, I have the pleasure of presenting my team and I's research project titled anatomical depth estimation and three-dimensional reconstruction and microsurgical anatomy, monoscopic high-definition photogrammetry using machine learning. Essentially, we're using machine learning to convert high-definition photos taken from a surgical microscope and rendering them into three-dimensional models that are anatomically and spatially accurate for neurosurgical education and training purposes. To the best of our knowledge, this has never been done before for microneurosurgery. Next slide, please. This slide shows the methods of our research project. The question we wanted to answer is the following. Can a spatially accurate 3D model be created from a single two-dimensional photograph taken from a surgical microscope during microsurgical dissection? We tested this hypothesis by dissecting one formalin-fixed, silicone-injected cadaveric specimen. An orbital-zygomatic craniotomy was performed, and a pretemporal transsylvian corridor was established to reach the tip of the basilar artery. The photos at the top of this slide show the sequential steps in the dissection. My team members and I chose a specific approach in surgical corridor because it offers different depth levels and anatomical structures that were considered appropriate for the evaluation of depth discrimination by the neural network machine learning platform. These structures are labeled 1 through 8 on the right image on the bottom left figure, and their names can be found in the table on the right. During microsurgical dissection, we took high-resolution photos from a surgical microscope. These photos were then inputted into a neural network machine learning platform. This machine learning platform was pre-trained with multiple images of video data sets, including 3D movies. The output is a depth map, which is demonstrated by the heat map image you see in the bottom left figure. The brighter the color of the heat map, the closer to the structure. On the other hand, the darker the color, the farther away the structure. Later, each anatomic structure was outlined as a region of interest, and a mean pixel value was collected. The photos of the surgical corridor were taken at 3 different magnifications, low, intermediate, and high. As one can notice, there's some blank spaces in the table because some structures can no longer be seen at lower or higher magnifications. To validate if these pixel values are spatially accurate, we measured the true depth of each structure relative to a baseline structure, which is the inferior phonogyrus. The depth measurements were taken using a neuronavigational system, which is the same technology used in surgery and can take measurements to hundreds of a millimeter. The values for each structure are shown in the second column of table 1. Next slide, please. On the left side of this slide, this is a result of our study. The right side is a figure from a project my team and I just recently published, where we validated at the macroscopic level the conversion of 2D images into 3D models using DICOM data. On the left, one can see 3 surgical dissection photos labeled A, C, and E, which correspond to low, intermediate, and high magnifications respectively. To the right of each dissection photo is the corresponding depth map that was created using machine learning. To the right of the depth map is a histogram that shows the frequency of each individual pixel value. The images to the right of the histograms are the scatter plots demonstrating correlation between depth and pixel intensity value of each structure. As you can see, the Spearman correlation value is high, and its relationship is significant, validating our 3D model. The complete 3D model can be viewed on a smartphone or tablet using the QR code found at the bottom of the slide. Next slide, please.
Okay, you're actually out of time.
Oh.
Perfect timing. So let's take a question from the judges. And while we do so, Patrick, if you could restart the slides. Some people are seeing gray bars on some of the slides. Dr. Shilkrat.
Thank you for that presentation. Can you just clarify for us how you're envisioning this being used?
Thank you for that question. That was our very next slide.
Sorry.
Because nowadays,
perfect question.
Perfect question. Nowadays, like having a cadaver dissection lab, yeah, these are the pictures, and having a cadaver is very expensive. Not very many institutions have this, and so by developing these models where we perform the dissections and we digitalize it and create it 3D, we can put it into a virtual environment like a metaverse. And we conduct workshops and classes and presentations with people from around the world. So if you look at the image to the top right, it's image D, you see there's a bunch of avatars there. And those are people from separate countries, from Turkey, from China, from Russia, from Puerto Rico, and from Chile. And we're actually conducting a microsurgical workshop showing these models, and they can actually play with it too. So we think that this can revolutionize neurosurgical education, neurosurgical training, and give to global neurosurgery a model that can be used for areas that don't have access to a cadaveric dissection laboratory or don't have access to cadavers and can learn this anatomy outside of surgery in their own time.
Thank you so much,
Thank you
Giancarlo.
very much.
Patrick, can we reboot the slides and see?
Yep, I'm gonna start it all over again. All right. Get rid of all of the PowerPoints. Restart it.
And for those of you, I know that probably some of the presenters could see gray bars over the last couple of talks. And so huge kudos to those that memorized their data well enough that they could present despite having us block out sections of their slides.
All right. Dan, Ivana.
For anyone who's ever seen the data blitz at the Society for Neuroscience, they intentionally do that to speakers to try to throw them off when they give their 1-minute talks. And it's really quite humorous. Here it's not, I think, meant as humor.
Well, actually, I plan to publish on this. You're all part of a neuroscience experiment, and we're kind of randomly manipulating. Some of you don't get audio. Those that do get audio are going to get gray bars over your slides. And wait till you see what we have planned coming up.
Can everyone see the full screen when I do this?
I don't see anything shared right now, Patrick. It's just the Zoom.
All right, let's try this again. Try it one more time. All right, start it up.
There's still bars on that one.
Yeah, is everyone seeing gray bars? Because I'm seeing nothing but a regular screen. And it's strange that it kind of started mid.
Yeah, I think we all are.
Yeah, I think most of us are, Patrick.
Yeah, I don't know what to say. It's
why don't you share the entire slide deck with me while the next person gives their talk, and I'll try to share from my side.
All right.
Can you just email me a link?
Yeah, I just have to close it out to send it. So I'm just going to drop, it's in my Dropbox. I'll just Dropbox it in one of your folders quick. Okay, it's in your letterheads folder. And we'll just get the next person ready. I want a dog. It looks like, just so we can be prepared, our next person is Martina Mustroff.
What slide are we on, Patrick?
Martina Mustroff.
What number? Give me a number.
Sorry, I had to close out because I had to share it with you. Hold on one second.
Dan Harrison. All right, Mariana, Peter, Giancarlo. All right, Martina. All right, let me try and share my screen. We'll see. Hopefully it works from my side. Okay, are people seeing slides? Hopefully without gray bars.
Better.
Yep.
Looks good.
All right, Martina, please take us away.
Hi, I'm Martina Mustroff. I'm a rising 6th-year neurosurgery resident at Brigham, and I'll be talking to you about some of the work I've been doing as a postdoc in the Williams lab at MGH for the last 2 years. Next slide, please. Humans display a wide variety of social personality traits. These social personality traits can range from being extroverted to introverted, being curious to cautious, being emotional to rational, and they can influence our ability to effectively interact with others and are often prominently affected in psychiatric disorders. The cortical network properties that underlie these traits and their dysfunction remain largely unknown, and so we undertook a project to look at what are the cortical network properties of these traits and their dysfunctions. Current research in humans is based mainly on non-invasive methods, such as functional neuroimaging, which has limited spatial and/or temporal resolution. As a neurosurgery lab, we have the rare opportunity to work with patients who are admitted to the hospital for epilepsy. And as part of the workup of their medically refractory epilepsy, a lot of these patients undergo stereoelectroencephalography, which means they have electrodes surgically implanted into different brain areas to try and locate the origin of their seizures. And because there's such a high comorbidity between epilepsy and autism, up to 20%, depending on what paper you look at, there's a high probability that we will enroll patients with more autistic traits than are found in the general population. And so we gave our 23 patients from MGH and Brigham the Autism Spectrum Quotient Self-Questionnaire, which consists of 50 questions that are designed to measure the degree to which an individual of normal intelligence displays autistic traits. Next slide, please. So here I'm just showing you the anatomic locations of the electrode contacts that we used to record from. We are looking at this for both high AQ scoring and low AQ scoring patients. We used an AQ cutoff of 31 or higher for high AQ and of below 31 for low AQ. And our locations of the electrodes ranged from the frontal lobe to hippocampus. You can see they cluster in the hippocampus, which is often where we find epilepsy foci, which fits with our clinical experience. Next slide, please. Here, we're showing you a power spectrum analysis of high AQ versus low AQ patients. And this is done for 10 minutes of resting state data that was recorded. The thin lines represent individual electrodes, and the thick lines represent the average power spectrum. In orange, you see the electrodes for high AQ scoring patients. In blue are the ones for the low AQ scoring patients. And since some areas are more heavily represented, so namely temporal and frontal lobe, you'll see more lines in those power spectra. If we look at the frontal lobe, there's a striking difference in beta frequency in high versus low AQ patients. There's also a striking difference in theta frequencies in the amygdala and then alpha frequencies in the hippocampus and parietal lobes between high AQ and low AQ scoring patients. We did not find any differences in power spectra of orbitofrontal regions or in the temporal lobe as a whole, but we conclude that there's certain social personality traits, in this case, autistic traits, that correlate strongly with resting state activity patterns in the frontal lobe, amygdala, hippocampus, and parietal lobes. And these are areas that we might target in the future to treat psychosocial disorders.
Okay, Martina, that was perfect timing because I just cut you off. Any questions for Martina?
Dr. Price, please unmute yourself.
Martina, thanks. Hard work, good work. Do we have norms? You're looking at the autistic spectrum disorder, but do we have it to map on the norms and see what's different of the personality and traits in psychiatric disorders?
Just unmute yourself, Martina.
Sorry, I was trying to answer on mute. Do you mean norms in terms of how people score on the AQ survey or norms in terms of resting state activity?
Resting state.
Resting state activity.
You should have norms on that, right? Yeah.
No, but that's a great question. We do actually have in our cohort of 23 patients, several that have an actual diagnosis of autism. And so I guess we could look at those as kind of a verifiable kind of resting state difference. The problem is we don't have that many who have an actual diagnosis. We're more looking at people who are high scoring versus low scoring and not necessarily clinically diagnosed.
Thank you so much, Martina. In the interest of time, let's move on to our next speaker, Rachel Olson. Rachel, are you with us?
Yes, hello.
All right, Rachel, please take it away.
All right, thank you so much. So, hi everyone, my name is Dr. Rachel Olson and I'm a fourth year triple board resident. Triple board training is a combination of pediatrics, general psychiatry, and child and adolescent psychiatry fellowship. And today I'm going to be talking about adapting the chronic care model to child psychiatry. And this was done through a pilot study through a general child and adolescent psychiatric clinic here at Tufts Children's Hospital. So before I jump in to talk about our pilot study, I'll give a little bit of background about the great demand that exists in this country for child psychiatric care. So 20% of all children in America have a diagnosable mental illness, but only about 1/5 to 1/4 of those children receive appropriate mental health services. And this is crucially important because the second leading cause of death among persons aged 10 to 24 is suicide. So I wanted to share this map with you. And what it is a bunch of teeny boxes that all represent different counties in America. And a huge portion of this map is blue. And that represents royal blue and dark blue are respectively counties with just one or no child psychiatrists at all. Next slide. All right, so to talk a bit about our pilot study, which was a longitudinal consult model that was rooted in the chronic care model. So the chronic care model was developed by Dr. Ed Wagner, which represents a successful model of managing chronic illness by emphasizing effective team care and planned interventions that puts the patient at the center of care. So we had 50 patients participate. They were aged 5 to 17. And these children were referred to the child psychiatry clinic from primary care providers or from pediatric subspecialists such as pediatric neurology or developmental pediatrics, or just from the community or self-referral. And these children, as part of the inclusion criteria, already had some psychosocial supports. So these were children who had a therapist or a social worker or a family partner. And a lot of these children had already been tried on psychotropic medication by their primary care provider, but that was proving to be insufficient. So our population, by definition, had moderate to severe psychiatric presentation. So these children were assessed at baseline, and we used different assessment screenings based on their diagnosis. And then we had follow-ups at 3-month intervals to reassess them. And throughout this time, we were trialing psychotropic medications and collaborating with their larger team, with the ultimate goal of referring them back to their primary provider to take over medication management.
30 seconds.
Okay, next slide. Okay, so our main findings, average age was about 12. The most common diagnosis was anxiety. And the main takeaway is that the median wait time from referral to access to care at the child psychiatric clinic was just 7 days, with an average wait time of 13.5 days. And this is really impressive given what a short time it is to get in to see a child specialist in that.
Sorry about that, Rachel. We just had to mute you on that last second there, but you really got just about everything in there. Great job. Does anybody have any questions? Dr. Fox can moderate.
Dr. Price, you have your hand up. Did you have a question, or is that from the last speaker?
Speaking of David or Bruce?
You, Bruce.
Oh, it was a gesture that wasn't intended for the screen.
It's a high five.
Do we have any questions for Dr. Olson? Dr. Perez.
Rachel, nice job. Where do you see this work going in terms of expanding and moving forward as you sort of work to team build and develop multidisciplinary programs?
Hi, yeah, thank you so much for bringing that up. So the inspiration for this program this pilot study came from MCPAP, which is this other program where there can be kind of like a one-off consultation with a child psychiatrist and a pediatrician. And I think like the larger goal is ultimately to have more integrated child psychiatric care embedded into the pediatrician's office, because so often there is such a long wait and such a long delay and so much trauma and damage that goes on until the kid actually is seen by the child psychiatrist. So figuring out a way to embed that and also perhaps educate pediatricians more so that they're more comfortable managing child psychiatric disorders longitudinally in a similar way that pediatricians are comfortable managing chronic diseases like asthma.
Thank you so much. So let's move on to our next speaker, Ahmad Ozair. Ahmad, are you with us?
Yes, good evening.
All right, please take it away.
Hi, my name is Ahmed Ozair. I'm a medical student in India. This work was mentored by Dr. Fawaz Al-Mufti, who is an associate professor of neurology and neurosurgery at NYMC. And so I'm presenting you today on who creates scientific evidence in stroke that is influential. This is an analysis of diversity and authorship of stroke-related Cochrane reviews. Next slide, please. So globally, we are increasingly acknowledging the need for equitable representation of authors, including in the clinical neurosciences. And we wanted to explore an area of clinical neurosciences wherein we could examine what is the status of diversity here in Cochrane reviews. And so we picked stroke, which is an interdisciplinary topic. And we know that Cochrane reviews are widely perceived to mean the highest quality of evidence available. We also know that they impact clinical practice globally. However, the current state of diversity in authorship of Cochrane reviews related to stroke was unknown, which this study sought to characterize. We searched the Cochrane library, therefore, for published reviews and we used the filter stroke, and then we meticulously extracted authors' details and searched the internet to determine their gender. For this, we tried to capture at least one web page that was public and that could be verified, that demonstrated their gender. We excluded all authors whose gender we could not determine, and we cross-verified all the extracted data through a second reviewer. Next slide, please. We included 209 publications with a total of 950 co-authors, and as expected, high-income countries contributed far more co-authors, with the top 5 being the UK, China, Australia, Netherlands, and Italy. But the surprising aspect is that only 1.3% of authors came from low middle income countries and 0% from Africa. The US contributed just 3% of authors, and of the nearly 80% of authors whose gender we could verify, women constituted for 50% of co-authors, first authors, and corresponding authors. Next slide, please. So authors from high-income countries do continue to be the biggest contributors to highest quality evidence in stroke, and women are well represented globally, both as contributors and senior authors. Interestingly, the US, which does contribute a lot to the global stroke literature, as seen from the most highly cited articles in stroke, which originate more than 50% of the time from the US, it has a much lower representation in Cochrane's efforts related to generating stroke evidence. So significant disparities continue to exist in representation of low middle income countries in stroke-related Cochrane reviews and perhaps in clinical neurosciences globally. So one is that we need to actively capacity build and in order to ensure that authorship diversity is enhanced. And second, we need to track these metrics and outcomes so that we can continue to do better. Thank you.
It's a great presentation. Dr. Fox, did you have anyone who wants to ask a question?
Any questions from our judges? Dr. Shokrat?
Just need to unmute yourself, Dr. Shokrat.
Sorry it took me so long. I'm curious about what kinds of recommendations you might make as to how to attain your goals.
Thank you so much. So one recommendation, so we specifically looked at Cochrane reviews because there is very minimal infrastructural funding required to be involved in a Cochrane review. You just need to have the right skill set. And so therefore we want to emphasize on training programs done with international collaboration, where we can have jointly conducted training training done in low middle income countries directed towards these countries, which is locally relevant, which can ensure that local capacity building is done, and then a sustained support program is done. And so we saw this in the US-India Cochrane program. So several people from the US and from the UK helped India develop its Cochrane centers, and people mentored us, and including at my institution, and it greatly helped us become involved in evidence, and we could contribute to evidence generation.
Thank you.
Thank you so much, Ahmed. Let's move on to Gyami Pagnier. Gyami, are you with us?
Yes, I am. Can you hear me?
Yes, please take it away.
Great. So my name is Guillaume Pagnier. I'm a neuroscience PhD student here at Brown University. I'm co-advised by Dr. Wael Assad, who's a neurosurgeon at Rhode Island Hospital, and Dr. Michael Frank, who's a computational neuroscientist here. So today I'll talk briefly about just kind of how we use computational models to link, to kind of make basic science clinically relevant, specifically in the context of Parkinson's disease. Essentially, I'll talk briefly, next slide, sorry, talk briefly about 2 treatments for Parkinson's disease and how they both result in impulsivity. The first one is replenishing the loss of dopamine with dopamine agonists and dopamine medications. There's been an array of empirical and computational studies in the past that show that dopamine or DA manipulates kind of our cost-benefit analysis of actions, which is great in the PD context because it emphasizes high DA levels, emphasize the benefits of an action, and decreases the costs, essentially producing more actions. However, it could also result in impulsive behavior because it also applies to cognitive actions as well. So think of going to the casino and high dopaminergic status. You might think that your odds of winning are maybe a little bit inflated, and that can account for kind of this increased impulsive behavior. You can click through the slides. Another treatment that you have is, back up a little bit, is STN-DBS, or deep brain stimulation. So also a relatively common treatment, even though it is rather invasive. This is also results in impulsive behavior, but the idea is that it's through a different mechanism, specifically through lowering kind of an action threshold. So which once again is great for PD, but can be bad for someone who's already a little bit impulsive. Next slide. So kind of these two mechanisms that I've kind of canonically called too much go and no stop and think. The idea, and I've kind of represented them here in this neat basal ganglia cartoon, both of them are useful in terms of treating the motor symptoms of PD, but can sometimes lead to more complications in the cognitive sense. Click through. So essentially, one of the kind of my goal as a PhD student is to try and develop a behavioral task that we could have PD patients perform that when they come in. And the idea is that based simply on their choices and reaction times on a task, neurologists should use that information to gauge what mechanism is kind of responsible for their impulsive behavior, because after all, impulsivity in both PD, DBS patients and DA treated individuals is all relatively common. Next slide. So pretty much I have STN DBS patients come into the lab. They play the simple cost-benefit decision-making game where they have to squeeze a hand grip dynamometer in return for different amounts of reward. The idea is that we can kind of parametrically modulate the amount of reward and effort that's required on each trial and kind of get an idea for how sensitive they are to the benefits and costs. Kind of a secondary benefit of this task is to explore what the different effects of DBS settings do. So essentially we have them, each patient comes in on and off their dopamine medication, go through each of these 5 conditions, and we go through. Click a couple times. So here's just kind of an overview. Unfortunately, I don't have enough time to really delve into these results, but this is just a quick sanity check. We already know that dopamine based on the...
Sorry, Guillaume, we had to cut you there. I've been obligated as being the hammer this evening, so I have to come down and be equal to everybody. Try not to start until you've given at least your name, and then so you get a few extra seconds out of me. Dr. Fox, do you have any questions? And also just to broach that we are going to be running over tonight. So I don't know if we should maybe cut questions and have them sent directly to the presenters after the fact.
Yeah, would that be okay with our judging panel? Conversely, the judges could enter a question in the chat during the talk, and that might save a little time as well. I see nods from our judging panel. So in the interest of time, let's move on to our next speaker. Cynthia Pang, are you with us?
Hello, yes, I am with everyone.
All right, please take it away.
Hi everyone, my name is Cynthia. I'm a PGY2 in psychiatry at the Brigham. Today, I'm going to be talking about the Artful Healing Program, which is a collaboration between the psychiatry department at the Brigham and Women's Faulkner Hospital and the Boston Museum of Fine Arts, MFA. Once per month, patients hospitalized on the psychiatric unit are able to take part in creative art sessions facilitated by MFA educators. The aim of the program was to enrich the experience of hospitalized patients during the recovery from acute psychiatric crises. Creating art also offers a unique outlet for emotional expression, especially when symptoms of psychotic or mood disorders can make more traditional communication difficult. The inpatient unit at Faulkner Hospital consistently offered monthly sessions between January 2020 and March 2022. Next slide. Selected examples of art patients produced and chose to donate are pictured here. Sessions initially took place in person in an OT room on the unit. The art educator would arrive on the unit prepared with supplies for each session, which were generally 1 hour long. During the pandemic, the art educator appeared via Zoom, and the sessions were facilitated by an occupational therapist and a psychiatry resident, myself, and my colleagues. Each session was structured around a specific art medium or style, such as mosaic, impressionism, pointillism, tapestry, or watercolor. Sessions would begin with a mindful observation of 1 to 3 images representing art of that medium currently housed at the MFA. Individuals were invited to share their observations and feelings in relation to the images. The remainder of the session involved an art activity, where the educator would provide guidance and demonstrate specific techniques, such as tissue paper collage or how to adjust pigment for watercolor paints, while patients were able to use these techniques for an art of their own choosing. All art-making material were in compliance with the safety standards of an inpatient psychiatric unit. Next slide, please. The Artful Healing program is focused on fostering an atmosphere of experimentation and inclusion, operating under the assumption that anyone might participate, regardless of their background in art. In exposing participants to a variety of art mediums and styles, individuals are challenged to release their grip on both perfectionistic tendencies and traditional expectations of art, what art should look like. Social interaction, interpersonal communication, and mutual support were facilitated through allowing individuals to create at their own pace. Here are some selected quotes from patients' feedback, which is overwhelmingly positive. Our short-term goal was to provide an outlet for creative expression. In the long term, we hope to be able to increase patients' interest in art by providing free tickets to the MFA on discharge to encourage them to explore their creative outlets. At the same time, by increasing the interaction between the MFA and patients, we hope to foster discussion on ways to continue to make the MFA more accessible to individuals living with mental illness. Thank you.
Thank you, Cynthia. You did that with 45 seconds left, not too shabby.
Thank you so much. Seeing no questions from the judges in our chat, let's move on to Aya Schnawa. Aya, are you with us?
Aya is doing night float right now.
Sorry, is that a yes?
Hi everyone, this is Aya.
Okay.
No, she's not. She's not present.
Talking about a research subject that
Can people hear this?
Which is the effect of spinal cord injury on the immune system. In that particular project, we studied the level of immunoglobulin.
We
have been hearing
lost
it, but
the audio when you put yourself on mute.
I'll keep it unmuted.
Historically, infections, particularly pneumonia, have been the leading cause of pre-hospitalization and death for this population. Individuals living with spinal cord injury are more than 80 times likely to die from sepsis than the general population. Increasingly, it's becoming more clear that the autonomic nervous system, which begins to exert at the level of T1, regulates the function of many systems, including that of the immune system. Very interestingly, in correlation to that, is that individuals with an injury level above T5 are the most susceptible to inflammation and infection. This is clinically relevant given the fact that the most common extent of injury pattern in the US is complete tetraplegia. In this study, we used ELISA multiplex to measure serum levels of immunoglobulins in 29 individuals with spinal cord injury compared to 25 controls without spinal cord injury. We found that IgA and IgG2 levels were significantly elevated.
All right, I'm hearing many people that can't see the slides. I don't know if you could hear the audio either. In the interest of time, I think we're just gonna have to skip the videos. Clearly, this was not set up to share videos correctly. And I apologize for those that send videos ahead of time. Valera Hutchinson and Aya Schnawa. Sorry, is this the same presentation? Or is this a new one?
It's a new one. I'll present this one.
Great. Valeria, thank you so much for joining us in person. Please take it away.
Good evening, everyone.
Hi, nice to meet you all. I'm Valeria, PY3 Neurology Resident at Tufts Medical Center and Leahy Hospital Medical Center. Today, I'll present a case about the feasibility of a HEPA filter feed valve setup for death by neurologic criteria, brain death determination in patients with COVID-19. So what prompted us to come up with a different setup for apnea test in patients with COVID-19 is that it's very common in these patients to have brain injury, usually from cerebrovascular disease, hypoxia, or other infections. And sometimes these patients end up having brain death, and sometimes and brain death or death by neurologic criteria is, yes. Sorry, there is like some technical difficulties with the slides, but I can keep talking. I just need to show one slide from it. But
So
yeah,
I'm going to stop share and reshare. I will give you a chance to represent, but I'm getting messages that no one can see the slides. And so let me try and reshare.
I did stop your timer, so I'll give you additional time.
Okay, thank you.
You can
optimize.
optimize audio and video when you do this. as
Yeah,
well.
I'm doing so.
Study stimuli with a class performance score scale of 10. We interrogated a HEPA filter in the endotracheal tube connection during
You
apnea
can
testing
mute
3 days
because
after
there is a
presentation to
recording.
minimize exposure to SARS-CoV-19.
I had no idea how to do that. We might want to just let the recording run.
Brain dead by neurological criteria, and none of the staff contracted COVID-19. This case highlights the feasibility of a modified apnea testing technique interrogating a HEPA filter to minimize exposure. This technique is particularly useful in patients with highly infectious aerosolized microorganisms such as COVID-19. Thank you so much.
All right, let's, I don't know if were people able to hear the end of that presentation?
If I is here, it'd be good to have her present like the second half, like the last minute and a half.
Yeah, can anybody tell me how to turn off the audio or the video?
Can I ask, by the way, Mike, a terrific job just for navigating many different steps. Valeria, do you have your slides at your end?
I have my slides. Well, that's kind of the important slide. I can just talk about that one. Can you see the slide?
Should we give her 1 minute to just cover this?
Please. Yes, please, Valeria. Is this the slide you need to talk about?
Yes, thank you so much. So, we basically, it was a case of a patient with devastating neurological injury, and the patient also had positive PCR like from nasal swab for COVID-19. And the patient, on the third day of admission, we performed apnea test. And this is the setup in the dummy, and in Exhibit B, we have a scheme of the setup. So we have the endotracheal tube that's connected to a HEPA filter, to a TP system with a PIP valve. And then we have the flow regulator, which is the oxygen supply for the patient. And basically, we tried these different setups for this patient to try to minimize exposure to COVID for the staff who were present during the test. None of the people who were in the room at the moment contracted COVID-19.
All right, thank you so much, Valeria. And sorry for all the technical problems.
This case highlights the feasibility.
Thank you.
All right, Patrick, can you please tell me when we're having recording presentations, and we'll skip over to the people that are in person in the interest of time?
Sure. I mean, some of them aren't labeled.
Okay, well, I'm assuming this next one is another one from Aya Schnawa, or is this redundant?
Well, I think you went back. That was the one that was previous to Valeria, and then Valeria's was Valeria and Ira.
Okay. Are we on Benjamin Thompson then?
Yes.
All right, Ben, are you with us in person?
I am.
Please take it away.
All right. Nice to see everybody. My name is Benjamin Thompson. I am a postdoctoral research fellow at Yale School of Medicine. I'm going to be talking a little bit about a study that our group conducted last year, and we published, in which we characterized the relationships between the multiple dimensions of change between many of the variables known to characterize recovery from alcohol use disorder. Next slide, please. So our sample consisted of 120 individuals, 60 of which were abstinent men and women with a history of alcohol use disorder, and 60 were healthy controls. Our recovery-related behavioral variable was duration of abstinence, and we used this variable to dichotomize the AUD sample in terms of short and midterm abstainers, which were those who had less than 5 years of abstinence, and long-term abstainers, which were those who had greater than 5 years of abstinence. We employed a variety of measures of affective states, and we collected all of the neuroimaging data on a 3 Tesla MRI scanner at MGH. All of these statistical analyses were used multivariate linear regression models. Next slide, please. All right, so what we found was that compared to controls, short and midterm abstainers exhibited significantly greater volume in the right posterior insula, as well as significantly higher scores on measures of negative affective states and significantly lower scores on measures of positive affective states. Also compared to controls, the long-term abstainers exhibited significantly lower volume in the anterior cingulate cortex and relatively normal affective profiles, with the exception of slightly higher scores on the depression index. And finally, compared to the AUD men, AUD women exhibited significantly higher volume in the anterior and posterior insula and significantly lower scores on measures of negative affective states and higher scores on measures of positive affective states. Next slide. All right, so in summary, we found that various durations of abstinence from alcohol were associated with distinctive neuronal and affective profiles. And this also differed between men and women. Our findings suggest that abstinence from alcohol may in fact be a behavioral intervention that will help curtail the negative affect and affective dysregulation commonly preceding relapse. Thank you.
Great. We've got 34 seconds left on that. So thank you for helping us regain some time. That was a great presentation, Ben. Dr. Fox.
Yeah, next up is Nafeez Turan. Nafeez, are you with us?
Yes, I am.
All right, take it away.
This is Nafeez. I'm a PGY4 neurology resident at Tufts, and I'm going to be talking about my research project on the use of balloon-mounted stents and drug-eluting stents in intracranial atherosclerotic disease. And I'll share our preliminary results. Next slide, please. So intracranial atherosclerotic disease can result in transient ischemic attack and acute ischemic stroke. And since the Stanford trial in 2011, which showed aggressive medical management was superior to ring stent angioplasty, the intracranial stenting has been reserved for patients who failed maximal medical therapy. And in this study, we looked at 27 patients between 2005 and 2020 that were treated with balloon-mounted stents, drug-eluting stents, and wingspan stents. And next slide, please. There's a lot of data, so I'll only try to point out the things that I think are important. So in this study, of the 27 stents, 57% were in the anterior circulation, and then 42% were in the posterior circulation. And 77% had angioplasty prior to the stent. And of those 27 stents, 10 were balloon-mounted stents, 14 were drug-eluting stents, and 3 were the wingspan stents. One patient had aborted procedure due to the patient's anatomy, and one patient received tandem stent. And the median stenosis was 76% before the stent, and residual stenosis was about 21% after the procedure. And as a neurologist, I looked at the mechanism of TIA and ischemic stroke and indication, and I want to point out that most of the time it was used for acute ischemic stroke and transient ischemic recurrent TIA. Next slide, please. And if you look at the early outcomes and the long-term outcomes, in the early outcomes, we see that none of the patients had TIA. About 20% had ischemic stroke, but the three of the 5 patients already presented with acute stroke, and 2 received thrombectomy. So, and the other 2 patients only had clinically silent radiological strokes. And in terms of hemorrhagic strokes, 1 patient had only small SAH, and the other one had SAH with IVH, but also received CPA in the setting of acute stroke. And the MRS was 0 median for all the patients. And 2 patients died that were acute basilar strokes that were treated with thrombectomy, and the care was withdrawn. For the long-term outcome, the follow-up was about 35 months. And if you look at the results overall, 12% had one-time TIA, 4% recurrent TIA, 12% ischemic stroke, and 1% had hemorrhagic stroke in the setting of ICAD and DAPT, which I don't think. And last thing is that wingspan stents were associated with restenosis more frequently than the drug-eluting and balloon-mounted stents. And looking at the results, I think this intracranial stenting is a viable treatment option with reasonable outcomes. And
All right, Nafis, we had to mute you on that one, but I think you made pretty much through it. That was great.
Thank you so much for an excellent talk. I appreciate that. Next up is Aditi Varmadoya. Aditi, are you with us tonight?
Yes, I am.
Great, take it away.
All right, so today I'm going to present on barrier reflex failure, which is an under-recognized and challenging neurological disease sequelae. So if you can please click. So we had a gentleman who presented to our clinic who had a history of nasopharyngeal carcinoma and received radiation treatment about 9 years ago. And he came in with orthostatic intolerance and syncopal episodes. And he would say that he was lightheaded, and every time he checks his blood pressure, it was either swinging between 70 millimeters mercury systolic and 200 at some points with no real pattern. So when we kind of asked him about seizure history, it was kind of not yielding. Dizziness, vertigo was not yielding. And so we just had someone with orthostatic intolerance and really labile blood pressures. When we did an exam, if you can click, please. So there were no carotid bruits. His systolic blood pressures were all above 190 at any positions, seated, standing, lying down. He had some sensory deficits in the form of vibratory deficits distally, some deficient ankle and patella reflexes, and a positive Romberg sign. So we wanted to work him up. We thought there was syncope, there was some dysautonomia, so we gave him a peripheral autonomic neuropathy workup. If you could please click. Kind of ruled out diabetes, gammopathies, vitamin deficiencies. We also evaluated for neuroendocrine abnormalities with blood pressure, so pheochromocytoma carcinoid was negative. We did brain imaging, which was negative. We did a cardiac evaluation with Holter monitors, also unyielding. If you could turn to the next slide and click, please. So an autonomic function test in our autonomic neurology lab kind of gave us some idea about what was going on. So this gentleman, if you could see the first pattern of his tilt table test, it shows that his blood pressure steeply declines, but his heart rate does not respond with a tachycardia. And if you look at the other slide on stand, again, his blood pressure steeply declines. And there's actually a bradycardic event, which makes no physiological sense. And so we understood that he was having baroreceptor reflex failure, most likely due to the radiation he received for his head and neck cancer. If you go to the next slide, please. And click. And so click again. So baroreflex failure for neurology residents and fellows can actually occur even post carotid endarterectomy, and it's very transient and acute, and it can worsen morbidity and mortality in patients. In our patient, it occurred chronically or subacutely because his the radiation he received kind of got fibrosis in his baroreceptors. And so if you could click on the slides, please. And so it's really hard to manage these patients because their baroreceptors are not giving them appropriate response. So we give them midodrine for low blood pressures and then clonidine for high blood pressures and blood pressure lability. So thank you. There's a picture of the baroreflex arc. And if you have any questions, I'll take them. Thanks.
Absolute perfect timing on the dot.
Thank you so much, Aditi.
Yeah,
Felipe Delado, are you on?
Yes, I am. Can you hear me?
Yes, Felipe, take it away, please.
Yes, Felipe, take it away, please. So thanks, everyone. So the name of my talk is Beyond Putting a Name to It, Phenotypes and Biomarkers in Neuroimmunology. I'm a third-year resident at MGH in Brigham. So this first slide here is illustrating the traditional way that we're phenotyping patients in neuroimmunology. And this is the way that most of you are probably familiar with. So we'll take the signs, the symptoms, the exam, the MRI features, and the CSF, and we'll usually come up with some set of diagnostic criteria to formalize a syndrome. And we're going to decide if the patient meets criteria for multiple sclerosis or if they do not meet criteria for multiple sclerosis. And that approach has worked okay in the last years. Sorry, still same slide, yeah. That approach has worked okay in the last years, but it has a lot of drawbacks. And those drawbacks are that a lot of the neuroimmunologic conditions that we're dealing with are very heterogeneous. And a couple of years ago, a lot of patients with what we would now call NMO, necrophorin 4 antibodies, would have met McDonald's criteria for MS and would have been treated as such. It works better if you have a disease that's a little bit more homogeneous, say Susac syndrome, where if you have a patient that really has that triad of encephalopathy, branch retinal artery occlusion, and sensorineural hearing loss, you can feel pretty confident that you're dealing with a disease process that's fairly homogeneous, and you're going to have better luck identifying a biomarker and potentially finding a specific treatment. But for things like neurosarcoidosis or multiple sclerosis, where the clinical presentations are heterogeneous, it's a lot harder. You're going to have a lot of different populations that you're studying. Next slide. And so what I'm proposing, instead of the traditional phenotyping, which is based on syndromes, is to take all patients with neuroinflammatory disorders, no matter the name we give it, whether it's multiple sclerosis, neurosarcoidosis, limbic encephalitis, Clippers, really it doesn't matter. Take every patient with a suspicion for a neuroinflammatory disorder, and you do essentially multi-omics immune phenotyping. So it's a couple of things that you could do. You could do flow cytometry to identify some transcriptional patterns. You can do single cell sequencing to identify transcriptional patterns, flow cytometry, standard cytokine release assays, metabolomics. And the goal of that is to identify potentially subgroups within these patients that we would have labeled as, say, neurosarcoidosis. And hopefully, next slide, please. Hopefully, once you've identified these subpopulations, you're able to find biomarkers and find targeted therapies. A good example of this would be neurosarcoidosis, which has multiple clinical presentations. It could have a myelopathy, they could have brain lesions, it could have leptomeningeal enhancement, it could have pachymeningeal enhancement. And maybe you're going to find that in patients that would have been labeled with neurosarcoidosis, some of them have more of a B cell mediated disease, some of them have more of a T cell mediated disease. And with that information, you'll be able to design more targeted treatment and elucidate the disease process. So my hypothesis is that using multi-omics phenotyping will allow us to better find biomarkers and targeted treatment for patients with neuroinflammatory disorders.
3 minutes on the dot, perfection.
All right, thank you so much. And I believe Galina Gaiman is our last talk, but we might circle back to Aya. Galina, are you with us?
I am. Good evening.
Take it away.
Hi, everyone. My name is Galina Gaichman, and I'm also a third-year neurology resident here at the Mass General program. And so excited to be here tonight and to share with you our experience with implementing an outpatient neurology learning series and our experience transitioning it to the virtual setting. Next slide, please. So as many of you know, neurology residency is heavily inpatient focused, and it underemphasizes outpatient disorders in terms of giving residents a chance to learn about these disorders and about learning how to manage patients in the outpatient setting. In order to address this gap, we initiated a novel didactic series where we presented facilitated interviews between an outpatient neurologist and one of their patients. And the idea of the series was to help residents understand the roles and responsibilities of the neurologist, model effective shared decision-making, and share patients' perspectives. Next slide, please. The format that we chose was to have sessions that occurred during our noon conference teaching hour. 4 sessions were piloted in person in 2016, and this was transitioned to Zoom in the setting of the COVID pandemic in 2020. And essentially, each of the sessions were very informal. And while they were prepared ahead of time, the patient and the provider were given a set of expected questions to help facilitate the interview. It was very much a discussion-based perspective where residents could hear the perspectives of both the provider and the patient. And we evaluated this with a series of interviews of the patient, the faculty surveys, and survey of residents at the end of the series. Next, please. And this gives you just an idea of some of the topics that were featured. Next slide, please. So I'll share with you the results, just highlighting the results from our virtual experience for saving of time. A majority of residents felt the sessions were as effective as traditional lectures. Many agreed that the key learning value was to hear the patient's perspectives, and many reported that the series helped them to understand outpatient neurology and in fact increase their interest in pursuing an outpatient career. All faculty found that these sessions were easy to prepare for without an added burden, and all patients also reported that this was a positive experience and they would participate again. Our responses were broadly similar for in-person and virtual sessions. So we were able to demonstrate, next slide, that this was a feasible format that helped to emphasize patients' perspectives of living with chronic neurological disease. They were much more engaging and preferred by residents to traditional lectures without adding additional burden time for faculty to prepare. This session not only increased residents' knowledge, so their understanding of underrepresented disorders, as well as the role of the neurologist, but in fact helped to position and adapt their attitudes in terms of increasing interest in outpatient careers. And hearing patients' perspective was considered essential, the most educational component, and patients appreciate the opportunity to teach. We learned that the way to best facilitate these sessions was to help prepare a guide in advance. And we found the virtual format did not diminish the educational value for residents and was acceptable for patients and faculty as well. Thank you.
Oh, perfect timing, Galina.
And you'll all be pulled at the end of this to see how the first virtual Cobb went and if we were as successful as virtual neurology education. I'm going to go back to slide 80. So Aya is with us. We butchered her presentation due to our technical difficulties. So we're going to try this one more time. And I believe, Aya, you had a video. And so let's go back to this slide 80 here. And Aya, are you with us?
This is Aya, one of the neurology PGY2s at Tufts Medical Center. Today I'll be talking about a research subject that I'm very passionate about, which is the effect of spinal cord injury on the immune system.
Yes.
In this particular project, we studied the level of immunoglobulins in individuals with chronic injury and actually found out that this population has elevated levels of both IgA and IgG2. What sparked interest in this topic is the fact that about 360,000 individuals suffer from this injury in the US alone, besides millions globally. Historically, infections, particularly pneumonia, have been the leading cause of pre-hospitalization and death for this population. Individuals living with spinal cord injury are more than 80 times likely to die from sepsis than the general population. Increasingly, it's becoming more clear that the autonomic nervous system, which begins to exert at the level of T1, regulates the function of many systems, including that of the immune system. Very interestingly, in correlation to that, is that individuals with an injury level above T5 are the most susceptible to inflammation and infection. This is clinically relevant given the fact that the most common extent of injury pattern in the US is complete tetraplegia. In this study, we used ELISA multiplex to measure serum levels of immunoglobulins in 29 individuals with spinal cord injury compared to 25 controls without spinal cord injury. We found that IgA and IgG2 levels were significantly elevated in patients with spinal cord injury when compared to controls. This is a crucial finding, as we know that more than 75% of individuals living with chronic injury have chronic systematic inflammation. We also know that in vitro experiments showed that serum IgA can promote signs of autoimmunity as well as inflammation, which are two known signs of immune dysregulation observed in chronic spinal cord injury, making the finding of this study crucial and a fundamental part in understanding the mechanism of this chronic injury and a gateway to explore pathways of infection, prevention, and potentially reduction of overall mortality. Furthermore,
okay, I'm told this is not working yet again. Aya, are you on? Do you want to try and share your slides?
Hi, I'm on. Actually, the most important slide, you guys, I think saw it. But basically what we were trying to get at is that in this study, we found out that also IgA levels were directly proportional to the degree of spinal cord injury, as patients with higher ASIA score had higher levels of IgA when compared to uninjured individuals. Finally, we know that the level of the injury in which the spinal cord injury occurred does not significantly influence IgA levels. So obviously further research is required to understand such mechanism, but the fact is that we know that there is an immunoglobulin related or increased in these patients goes along with the fact that they have immune dysregulation. So this is the crucial finding of this study. And basically what we're trying to do next is characterize early innate and late adaptive immune responsive in patients with spinal cord injury, specifically after getting vaccinations. Thank you.
All right, thank you so much. And I want to apologize to everybody that this was not a fair competition. There was a lot of interruptions, technical problems, and as expected for the first ever Cobb Assembly. But thank you everybody for helping. Just give me a second here. We're tabulating all of the scores from the different judges. It'll give me just a couple minutes to make sure that I can highlight the high scores. All right.
While Mike's doing that, I just want to congratulate everyone. Really a fascinating evening, a lot of fun and interesting presentation.
I think one of the finest aspects of it was to see the equanimity of every single person dealing with the frustrations of trying to present very important work in an environment in which nobody's fault. It's just we're living in a hard environment. But boy, it's a sign of being a seasoned doctor to be able to tolerate the rough ground. Thank you, all of you who presented.
Wonderful presentations, everybody. Really interesting across the spectrum, from education to clinical cases to primary research, case controls, large series. Very nice, really very entertaining, good science, and well done.
Yeah. So I would say it was a good cognitive and emotional stress test, like the cardiac treadmill, and you all passed with superb scores. Well done for your flexibility.
Also, I'll say we do have all the slides available for the judges to review as well. And if any of you would like to share, give permission or not give permission for your slides to be shared, just shoot me an email. I will put my email in the chat.
I'm especially thrilled that we had people who were not just from our geographic area and not just from the US. So thank you very much for participants from all over. And just reiterating what other people have said, I just find it astounding and thrilling how many different areas of interest people have. And of course, I'm interested in why each of you is interested in the area you're interested in, but that for another time.
Barbara, do you think there should be an award for the person who's in the worst time zone for this moment? Because I think like the people in India, it might be like 4 a.m. over there or something.
Yeah, exactly.
Also, thank you to everybody for staying on much longer than we had anticipated.
All right, and the results are in. Thank you, judges, for entering.
The envelope, please. The envelope, please.
And it was a very close competition, but our top scoring clinical presentation goes to Daniel Harrison at MGB. Thank you so much, Daniel. Our top scoring basic research award goes to Peter Loro from Brown. And our top scoring presentation overall, the Stanley Cobb Award for the first ever virtual Cobb Assembly goes to David Fisher. So congratulations to the three of you, but congratulations to everyone for being part of this first ever experiment of the Cobb Assembly. I'm glad that we did it despite all the technical difficulties. We almost canceled it for a second year in a row, but I'm glad we did it. Thank you everybody for participating. Thank you so much to our judges for being willing to give up their Thursday evening. And we will be sending those $100 prizes in the mail. But thank you so much, everybody, for joining us.
And just finally, the winners, my email is in the chat. Just send me your home addresses. We can get those checks out to you.
Yeah.
Congratulations, everybody.
Yeah.
Well done,
kudos to Patrick Flynn. Kudos to Mike. Kudos to Barbara.
Yeah, Mike, Barbara, really terrific. They did an absolutely great job. It was wonderful. And, it's 9 o'clock here in Nahant, Massachusetts too. Imagine I stayed up this late. It was such a wonderful thing.
Yeah, and thank you, Ahmad, for being present from India. We appreciate your contributions. It was a great talk.
Good night, all.
Thanks, everybody.
Thank you, everyone, for staying on.